Doctors call it an awake craniotomy. But for you and me, it's more like, wait a minute, you're going to do brain surgery on me while I'm still awake? And it's not just brain surgery. Patients are remaining awake for orthopedic operations, those of the breast, the colon, some cosmetic procedures. We talk about this style of brain surgery with a man who does them for a living, Dr. Philip Stieg. He's with the Weill Cornell Medicine Brain and Spine Center in New York.
The reason to have a patient awake during any surgical procedure would be that you have a concern about the impact that your surgery might have on a critical function. The example would be that you're operating on the brain, and if you're worried about vision or speech or motor function, you would want them awake so that you could test those functions while you were performing the surgery.
How many of these have you done?
A couple hundred for various types of pathologies.
I'm not going to ask you if you enjoy it because, of course, your main concern is the patient, but do you find it an interesting type of surgery, if I could put it that way?
Oh, it's absolutely interesting, and I would say that it's enjoyable for the patient depending upon the length of the surgery. And the reason I say that is, as you know, I presume if you wake up in the morning and you've been laying and sleeping in one position for 8 hours, your body aches a little bit versus if you have the common sense to roll over. The same thing applies to the patient. If they have to sit in one position for a long period of time, it's painful. In addition to that, another reason why patients like the awake craniotomies is that it's a different anesthetic agent, and the reversal or coming out of the anesthesia is much more pleasurable, and they don't have the associated side effects such as nausea and vomiting.
But you're having a conversation with them. I mean, that is the whole point here, even as you operate.
Absolutely. I mean, there are components of the case where the patient is asleep. We're not using general anesthesia, but they give them a sedative that is easily reversed. And then when we need the patient awake, they can start waking them up, and within 5 minutes, they're there for us to move a body part, read something, or respond to us verbally.
How do patients and their families feel about the idea when you first propose it, introduce it to them?
Some patients are quite frightened by it. Oh my God, you're going to be operating in my brain while I'm awake. Other patients are intrigued by it, and a good many follow your lead. And by that, you present doing the surgery in an awake fashion as an advantage to them so that we can make sure we preserve important neurologic function.
Not everyone may know that the brain itself feels no pain. Is that correct?
Absolutely. That's the one advantage, is it does not feel. When we are going in, the only things that the patient can feel is the scalp and then the bone, and then there's a covering of the brain called the dura mater, which is actually the most sensitive, and we have to numb that up as well.
Can we talk about surgery without cutting? Is that a trend that we would all benefit from if it can be done effectively?
Technically speaking, we've been doing surgery without cutting for now about 65 years with the advent of what was called the gamma knife. That is called stereotactic radiosurgery. What that represents is we can stereotactically deliver beams of radiation and target it only at the abnormal lesion that's within a patient's brain, not affecting the surrounding brain. It is very effective when selected for the appropriate lesions. I'm a strong advocate of that. We've been doing it for a long time. There's obviously a little bit of invasion. I'm kind of going up the invasive ladder now, where we do things what is called endovascularly, where we put little tubes into the artery in your groin. And many patients will relate to this when they think about coronary artery stenting. And instead of putting a stent in your coronary artery, what we do is we can thread these catheters, rubber tubes, up into the blood vessels of your brain, and we can pack what are called aneurysms, blisters on your blood vessel with either coils, or we can put stents into the brain as well. There's not really a cut, there's a puncture to do something like that. Again, that is something we've been doing for a while, but over the years we've refined that technique and the technology has gotten significantly better.
Are there cases where you simply cannot keep the patient awake? In fact, it would be detrimental to do so.
It's not a reason for detrimental. It's, you're thinking about patient comfort. As you can imagine, if we're operating, in many cases, when we're operating on a patient's spine or we're operating on the back part of their brain, they would be laying on the operating table in the prone position. That obviously isn't a comfortable position to be in for a long period of time, so they're better off asleep. And then for larger operations where we're going to be operating for extended hours, or the anatomy is complex, but we can't monitor it, you certainly wouldn't want the patient awake for that.
I suppose one takeaway is the next time your surgeon proposes this, don't be shocked because it's happening more and more.
Absolutely. And, even in regard to the, minimally invasive, you were talking about surgery without an incision. I think the step between what we're doing and the surgery without an incision is also what's called minimal access or minimally invasive surgery, where we operate through the nose with endoscopes, or we're just putting laser beams into the brain to treat certain lesions. All of those things are becoming much more common. And hopefully within the near future, we will be talking about molecular neurosurgery, where we're implanting viruses that will attack human brain tumors.
Dr. Philip Stieg with the Weill Cornell Medicine and Brain and Spine Center on Skype, giving us a little window into the future of medicine.